Pleasure to introduce to you our two speakers, Renée St Onge, Director of the Resources, Research, Evaluation and Development Division at the Sudbury District Health Unit. I had to write that one down for me. I wasn't going to remember all of that. And Sandra Laclé, Interim Chief Executive Officer from the Sudbury District Health Unit. So thank you to the both of you for joining us. We're very happy to be here in your beautiful city. Renée and Sandra will present an overview of the concepts of health equity and the social determinants of health, as well as Sudbury's 10 promising practice frameworks to reduce social inequities in health. Developed locally, this framework has guided the work of the health unit, however, is broad enough that it is applied here locally and can be applied to work we do in social and human services. So welcome, Renée and Sandra.
Thank you, Kira, and it is really our pleasure to be here today to have a conversation with our colleagues in Health and Human Services. As you know, we both come from public health, and we're going to present you with the framework that we use to guide our work in public health at the Sudbury District Health Unit. So, as Kira said, I'm here with Renée. Renée is the director of our Resources, Research, Evaluation and Development Division, or RRED for short, at the Sudbury District Health Unit. And my usual role at the Health Unit is Director of Health Promotion Division, and I have a short-term secondment right now as the Interim CEO. Much of the work that we're presenting here today can be attributed to others at the health unit as well. So in addition to ourselves, certainly all of the staff at the Sudbury District Health Unit, our former health equity office at the health unit as well, our medical officer of health, Dr. Penny Sutcliffe, and our board of health. And we have with us today from our board of health, Evelyn Dutrasac. Delighted that Evelyn is here in the audience. So, why are we here? So to start, during our presentation, we're going to define health equity and also inequities in health, and we're going to provide you with an evidence-informed framework that we use in public health as we work toward the goal of health equity. So after that, Renée is going to provide you with an example of how we've used the framework in our own practice, and then we're going to end with 15 minutes of time at the end for questions on how this framework, or discussion, dialogue, and how this framework can be applied within your own sector. First, a little bit about the health unit. The health unit covers a geography of 46,000 kilometers, extends 3 kilometers in all directions, so north up to Chapleau, includes the city of Greater Sudbury, also includes Manitoulin Island, French River to the south. The city of Greater Sudbury and the district of Sudbury is where 80% of our population resides, and in total our health unit provides services to 200,000 people in 19 municipalities. Also of interest, there's 13 First Nations communities within our catchment area, and about 26% of our population has French as a mother tongue. Public health in Ontario receives its mandate from the Health Protection and Promotion Act, and the purpose of the Act is really threefold: to provide for the organization of and the delivery of public health programs and services, also the prevention of and spread of disease, and finally the promotion and protection of health of the people of Ontario. So really today we're talking a lot about the prevention of the spread of disease and the promotion and protection of health of the people of Ontario, including all people who reside in Ontario. From the Act extends the Ontario Public Health Standards that were established by the Ministry of Health and Long-Term Care in 2008. And these Ontario Public Health Standards establish the requirements for fundamental public health programs and services. So things like, there's 4 of them: assessment and surveillance, that's one of our foundational requirements and fundamental requirements; health promotion and policy development, so that could be working with Health and Human Services, it could be working with municipalities, could be working with other municipalities, boards of education, for instance. Also, disease and injury prevention, and finally, health protection. And I think, when I say health protection, you probably think of the public health inspectors also, who are employed in public health. So throughout the standards as well, that we in public health often call our mandate, the word determinants is mentioned 15 times, and the word inequities is mentioned 13 times. And to us, this demonstrates the importance to the Ontario Ministry of Health and Long-Term Care, and specifically the public health sector, to the concept of determinants of health in improving health equity or reducing inequities in health. So what is health equity? What is health inequity? Couple of definitions. The term health equity, as it says on the slide, implies ideally that everyone could attain their full health potential and no one should be of disadvantage from achieving this potential because of their social position or other socially determined circumstance. And the term health inequity are the differences in health status experienced by various individuals or groups in society. These are systematic or socially produced, they're modifiable, and they're seen as unfair or unjust. Oops. Oh, had to go back one. Had to go forward one. And back one. There we go. So, as I read the definition of health inequity on the previous slide, I gave you a couple of moments while I was switching back and forth so that you could think about what those things were. So your mind may have shifted to those systems and social demographic factors that cause health inequities or that prevent people from attaining their full health potential. So the top of the iceberg, or the tip, right, of the iceberg, is the physical health status that's immediately visible, identifiable, and often measurable. The tip of the iceberg shows, however, only a small part of the overall picture. Right below the top of the iceberg, or the tip, is the section just at the water, or just below the water's edge, and this is often referred to as those behavioral and lifestyle factors that contribute to health. And then you look at the bottom, and the bottom section represents the social determinants which have the greatest impact on health status and influence and contribute the opportunities, the exposures, and the behaviors that contribute to health. These make up the bulk of the iceberg. They're not always immediately obvious, but they have the potential to offer the biggest health gains. Specifically, we're talking about the factors in our society like income, social status, education, and employment, just to name a few. And the social determinants of health are fundamental to health promotion. Health promotion strategies in public health, or our work in general, need to address these factors or mitigate the implications of these factors, as many differences in health are socially created. This is another way of looking at it. And also, too, you may have seen the slide. It's often used about people falling into the river and, going to retrieve the people from the river, and then another one falls in and you're retrieving that person, another falls in, you're retrieving that person. So you're exhausted from this effort and you finally decide to go upstream and find out why everyone's falling into the river. That's another way that people often talk about the determinants. This here, along with, so we have the iceberg or the falling in the river story. This slide here talks about the gradient, because people can be here or people can be here, but if you look, there's a gradient in between. It's not all here, or all here. It affects everyone. So a little bit about the gradient now. The health and social economic status, so people's health and social economic status diminish continually along the social gradient in health, and so as their exposure to each of the social determinants that you look at in the wedges that you see, and those were similar to the pieces underwater in the iceberg, the biggest part of the iceberg. So as our exposure to each of these social determinants becomes more and more negative, and the wedges get wider and wider because it's more and more negative, The slope gets steeper and steeper. So as a result, our ability to achieve optimal health is compromised. These social determinants get added together or get larger in magnitude, and as that happens, it gets harder and harder and harder for people to push that health hazard ball up the hill. And the opportunity for good health is less and less. So this happens through a variety of pathways that you may be familiar with, things like material deprivation, so inadequate food, inadequate shelter, social exclusion, the inability to participate in cultural, economic, educational, political, and other societal activities normally expected of individuals, families, and communities, a lack of social supports, coping mechanisms, increased stress, and also when this happens, the healthy choices are not the easy choices. Fast food is cheap, neighborhoods may not have places to play, or they may be perceived as not safe. Smoking is perceived as a coping mechanism. However, the opposite is true. If a person has more positive exposures to the social determinants, so good education, safe housing, food security, and a good paying job, the slope becomes less and less steep. Every one of those wedges gets smaller and smaller. And the pathway to good health is more realistic. The ball of health hazards that one has to push along their path to health is smaller. The slope is not as steep, and the opportunity for good health becomes easier. So regardless of our practice setting, whether it's health or municipal social services, the services that we're providing either directly or indirectly reach people that may be at risk for health inequities. This includes, not limited to, the population groups that are mentioned on this slide. So persons living on low income, homeless, Aboriginal people, those with limited education, isolated, living with disabilities or mental illness, facing discrimination, and those may be, of course, very familiar to you, as known often as the social determinants of health. So how do some of these characteristics translate into our local community or the catchment area for the city of the Sudbury District Health Unit, including the city of Greater Sudbury? According to some 2011 statistics from a national household survey, poverty affects 13.2 individuals in the city of Greater Sudbury, about 2,050 children under the age of 6 in the Sudbury District catchment area, so the 300 kilometers north, Manitoulin, French River, the whole area. 12.8% of Sudbury District Health Unit adults 25 to 64, again, whole catchment area, have not completed high school. 7.8% are 15 plus are unemployed. Now this is 2011, includes the whole catchment area. So I just want you to think about where you work, where you come from, where your residence is. It may be different, it may not be that much different. Again, health is for all. So to achieve health for all, everyone's health has to improve. However, the only way to narrow the gap in health in an equitable way is to bring up the health of those groups who are worse off to the health of those that are better off. At the health unit, we often use our hands. If you've spoken with anyone at the health unit, you've seen us do this. We're not juggling, but really what we're trying to say is everyone's health needs to go up. But at a population level, like thinking of this at a population level, the health of the worst off needs to come up faster. So everyone is moving up together, and everyone has an opportunity for health. So with all of that, we knew at the Sudbury District Health Unit, as in all health units, that we had to do something. And we knew that there was evidence, but we didn't know where to start. We didn't know what to do. This is what the rest of our story is about. Staff at the health unit were saying to us things that are mentioned on the slide there, some direct quotes. We knew we were committed to addressing the social inequities in health, but what exactly can we do as part of our local health practice? And, based on these questions, we knew where we had to start. So, 3 staff at the health unit, Dr. Penny Sutcliffe, our medical officer of health, Susan Snelling, who worked in our research division with Renée, and myself received an opportunity to apply for some intervention project funds through the Canadian Health Services Research Foundation in a program called Executive Training and Research Application, which is known as the EXTRA program. And we needed an intervention project So from the work we had done, our topic was really clear, and we knew that we had to find out or figure out what could be done at the local public health unit level to reduce social inequities in health. So our extra team, with support of many staff at the health unit, our library staff, for instance, we identified 10 evidence-informed local public health practices to reduce social inequities in health. And I just want to tell you that the practices are not based on random controlled trials, that much of the evidence that we found was suggestive, it wasn't definitive. There's not a lot of evidence-controlled trials and publications, based on evidence-controlled trials. Much of our work was found in the grey literature. We probably could do a better job of publishing within our sector as well. So anyway, this was the state of today's evidence. So instead of calling them best practices, we've called them promising practices. And we have shared the promising practices far and wide within public health, and they seem to resonate. So they certainly have that face validity within the sector as well. So here they are, the 10 promising practices in the framework. So as you can see, from the 10 promising practices, we've grouped them. Some of the practices are applicable to lifestyle-focused areas, which is a place where we do quite a bit of work in public health. And the other practices are related to policy-focused areas. And some of the practices span both policy and both lifestyle, depending on the types of actions that are carried out. And also you'll notice there's other practices along the bottom that are cross-cutting, and so they're not specifically related to lifestyle or to policy work, but really are those foundational cross-cutting practices. And we're going to spend some time on each of the 10 of these promising practices. Renée is going to give you some examples of how we've applied each one of those practices at the health unit. And as she's doing this, I'd ask you to start to think about whether or not you can apply that practice in your sector. Is it relevant to you? Is it meaningful to you? Can you use it? Can't you use it? Would you like to use it? And at the end, we'll have a discussion. So thank you, and over to Renée.
Thank you very much, Sandra. So as Sandra mentioned, I'm going to take a little bit of time to provide you with some concrete actions or concrete examples of those promising practices in action. I think what's important to point out here is that with respect to those promising practices, some of them are practices that we as a health unit have taken a leadership on, and others are practices that we have collaborated with our partners on. And where I can, I'll try to make that distinction. So the first promising practice is social marketing, and the first thing that we did was we took the promising practices framework and we said, in order for us to be able to really put these practices in action, we need to educate our staff and give our staff the tools necessary to be able to move forward with these practices. So we developed these 10 promising practices fact sheets, with some concrete examples, and those have been really have really been some internal social marketing strategies, and social marketing being one of the first promising practices that we really tackled and put our head around. The next promising practice I would like to speak about is called the targeting within universalism. So if you think about a universal approach, access to services for all, and that is essential to our success, and it's important to have services available to all. But if you think about a targeted universalism approach, we know that access is more difficult for some than others, and so we try to utilize a targeted with universalism approach. One really good example of a targeted with universalism approach is that with respect to our sexual health services at our local public health unit, while the services are available universally, we move the office where those services are offered to the downtown core so that it could be accessible to those who may be more vulnerable or more at risk. So that's an example of a targeted program. This is another example of targeting, and this was under the leadership of the City of Greater Sudbury, the Social Planning Council and school boards, with respect to best start hubs. So using a number of indicators, locations for the hubs were strategically chosen, and they continue to be assessed to ensure services are meeting the needs of the population and that the hub services are accessible to all segments of the population. Some of the indicators they used was employment, education, EDI scores, lone parent families, and so on and so forth to really target that program. We also have core and universal schools. So with our own school health program, we've selected, in partnership with the local school boards, some core schools, and those core schools get an enhanced programming. So there is a universal school program, but there is some enhanced programming within those schools. Purposeful reporting is another promising practice. The World Health Organization identifies the importance of reporting purposefully on the relationship between health and social inequities in all health status reports. Our health unit is stratifying the data as much as possible in all of its health status reports. For instance, with chronic disease, we'll stratify that by income levels or education levels, low birth weight by income and education levels. Opportunity for All is one report where we stratify the community by the areas of most and least deprivation, the City of Greater Sudbury, and then we tried to determine whether or not there were some differences with respect to a number of health outcomes or health indicators. So this report was produced just last year and it is available on our website. This is an example of what's in the report. So it's our mapping. The areas that are red would be areas of highest deprivation, and then the areas that are green are areas of lowest deprivation, and then the gray are the neutral areas. And then we have compared a number of health indicators with respect to those areas. This is one example of what the data looks like. So you can see with respect to premature mortality, the most deprived areas have higher rates, and that is a statistically significant difference. Early childhood development is another promising practice that focuses on implementing early childhood interventions with a focus on policy and programming. So one example of that is the Baby Friendly Initiative, which aims to increase the rates of mothers who begin and continue to exclusively breastfeed for the first 6 months and then beyond. Some other examples in our community include Triple P parenting, which is something that we work on collectively with other community members, and also the Best Start Hubs, which I mentioned earlier. Health Equity Impact Assessment. Some of you might have attended the workshop that was led by Martha Andrews earlier this morning. So Health Equity Impact Assessment is something that will help you identify what are the potential health impacts of a policy or program, a new policy or program, whether some members of the community will be more impacted than others, and how the negative aspects of a policy can be minimized. Intersectoral action is another promising practice. And I know I'm running out of time, so I'll try to get through these a little bit more quickly. But it's critical to building health for all because many of the solutions to addressing social inequities in health lie outside the health sector. And you saw that by the Let's Start a Conversation video. We as public health need to work with our municipal partners. We need to work with our school board partners. We need to work with the police. We need to work with social services and so on and so forth to really be able to make a difference together. Oops. Some examples of intersectoral action in our community: the Partners for Children and Youth, Community Mobilization Sudbury, NOAA Space, Data Consortium, the Best Start. 61% in 2013, we did an assessment of our partnerships, and 61% of our partnerships are intersectoral, so that is outside of the health sector. So, we're really proud of that, and I think it's something that we should all be working toward because we all have different parts of the answer to the solution. Organizational standards. Sandra mentioned earlier that we have the Ontario Public Health Standards which guide us, and I would say that having these standards in place and having social determinants of health and health equity as part of those standards gives more teeth to the work that we do, gives more credibility to the work that we do, and certainly gives an impetus to all public health units to really work towards addressing social inequities. As far as our structure goes internally, this is another sort of standard, but more at the micro level, having the leadership of the medical officer of health, the board of health, having a health equity knowledge exchange and resource team that provides resources and transfers knowledge across the organization, and also having a health equity steering committee. So having this structure in place gives us really a launching board to move forward with putting these practices into action. And finally, not finally, there are a few more, but Sandra talked about the importance of having that evidence base for us to really be able to have more solid evidence to support the work that we do. So I think it's important for all of us to think about how we can contribute to that by publishing, by translating knowledge, by coming to conferences and really getting the word out there so that we can build that evidence base. Community engagement, so it's important to work as part of your community, and I think you'll probably notice that not all of these practices are mutually exclusive. So when you think about intersectoral action, you also think about community engagement, and that is an important practice. Health equity target setting, it's important to have some targets to work toward. It's important to measure our achievement of those targets. So there is a group provincially that is working towards testing and fine-tuning some indicators to really determine how public health units are achieving health equity and how they're making progress towards health equity. Oh, I made it. So I will hand it over to Sandra. So you will see that, and I apologize, there were 10 practices and I tried to get through them really quickly. Some of you can come and talk to us afterwards if you want a little bit more information. But I think that you can see with these practices that it's important for all of us to be working together. So we're here as public health, and we're really, really thrilled to be here to talk to you and to talk to folks from your sector, because we as public health can't do this alone. None of us can do this alone. So thank you.
So as Renée said, thank you very much. And so we've provided you with an overview of the framework and the 10 promising practices. So if you look at the 10 promising practices, again, we talked about targeting within universalism with the sexual health clinic, with the school base. So really targeting to ensure that those individuals who may not traditionally had been able to access their services are now better able to access services. Social marketing, so tailoring messages, the importance of early childhood development. We talked about purposeful reporting and disaggregating data, so everything doesn't fall to the mean, but everything is disaggregated, so the evidence is out there for the decision makers who need to see the evidence to make the decisions. Talked about working together. We all have a piece of the puzzle. The importance of equity-focused impact health assessments. So certainly when we're developing key policies, the importance of putting that lens in front to see how that policy is going to impact others in the population, to decide whether or not we still want to go forward, whether we want to put something in to mitigate, or if we don't want to go forward with a policy. The importance of organizational standards, how critical they are, and that was by having that added to the mandate within public health, it gave permission to all of the health units in Ontario to move forward. So if there was any hesitation, there's no hesitation anymore. Certainly the contribution to the evidence-based, engaging with community, citizens in community, and also setting targets, and that's difficult to set targets, and targets at the societal level and maybe at our own organizational levels. So with all that being said, we have 2 questions in just a couple of minutes, and certainly we are available by phone also, and we'll be here for a few minutes, but are you using any of these promising practices in your work, or are there any promising practice that you saw here today that you think you could use in your work? So by all means, just feel free to share with us. And you may not be calling the promising practice by its name, but and Patty, going back to the video, health and human service workers, teachers, educators, lawyers, doctors, dads, health and human service, social service workers included there as well.
Yeah, so our department's integrated, and so we've started doing social media messages out between social housing, social services, and public health. We have a communications officer that works across all 3 divisions. So she can, if she gets a message from one of the divisions, she can make sure it's aligning with what's happening in the other two divisions. We've done joint reports to council. The health unit's
Yeah.
required to do
Health
food
status.
basket
Oh, yeah,
costings.
yeah.
And we used to just report on that. Now we don't do that. We call it a food insecurity report. And we include housing information, social services information, and the costing of the food basket to talk about how the incomes are inadequate to not only eat healthy, but to live safely. And so that we need to do something about the income. So that's just a few examples of kind of where we've been going. And we're one of the 23 health units that have redone the video. Thank you to Sudbury for being the leaders in this. They give you the rights to the video. It's, I can't remember what it is, $2,000 to put your own local data in, so it's very inexpensive for a very effective tool. We use in lots of places.
Well, don't hesitate to connect with us at any time. We believe our presentation will be available to you after the conference and with our contact information. And thank you very much.